Here to talk to you, and I always love talking about research. It's one of my favorite areas of interest. And what I want to do is as Claudia said, acupuncture and depression is my topic. And what I'm going to cover is, this is roughly my outline. Some of the challenges of antidepressants, looking at a review of acupuncture that we did in 2010 with Cochrane, a large-scale trial that will form the major part of the talk, and then also really important is what sort of impact has it had. And I'm going to talk about NICE, which in the UK is the National Institute for Clinical Excellence, and it sets policy, so it has a big impact, and it's picked up in other countries as well. And then I'm going to talk about the Cochrane, the update, the Cochrane review in 2018. And then just a bit of a comparison for depression with other treatments. So, antidepressants, in preparing for this talk, I thought I'd just look at withdrawal effects and how many people use antidepressants. And I have to say I was shocked. In the UK, 16% of the adult population, that's roughly 1 in 6 adults, are taking antidepressants. Do you think, isn't that rather a shockingly high proportion? I certainly was shocked. And more than half the people who are on antidepressants have withdrawal effects. Now that's not the image that antidepressants have, but it is, from this research, that's a real problem. So there's a need for alternatives. Oh, there's one other thing I found, was looking at the size of the effect. In acupuncture, we get criticized for having a small effect, often when we've heard that a few times today, having a small effect. Actually, antidepressants have, compared to placebo, have a minimal or non-existent, on average, effect for mild to moderate symptoms. So there's a real problem out there, because antidepressants have a high profile, and I'm not sure they deserve that. So, going just to a review that I was involved in with Caroline Smith from Australia, we looked at acupuncture for depression and published in 2010 a Cochrane review. And we found insufficient evidence to recommend the use of acupuncture for people with depression. But also, the majority of the studies, that's 24 out of 30, were undertaken in China, and 26 recruited participants from inpatient hospital settings. So this isn't the typical situation that people in the West have when they receive acupuncture for depression. And I didn't write this, but it was quite a useful platform for the trial that we did subsequent to this. Future studies may need to consider the use of comparative designs. In other words, comparing acupuncture to other active interventions or to usual care. And this particular review wasn't promoting the use of acupuncture versus a placebo as an important step for the research. So I'm going to talk about a trial that does just this in a comparative design. So this is the AcuDep trial, and it's a 3-armed pragmatic trial with 2 controls. So there's an acupuncture arm, an active control, and a usual care control. And a pragmatic trial tries to mirror what normally happens in routine practice. So in that sense, it's pragmatic, it's practical, it maps really what happens if, for instance, a GP refers a patient to an acupuncturist. This is a sort of likely outcome, on average, that might be expected. But there was no placebo control in this trial, so in order to take, and to some extent, control for placebo effects, we measured preference and expectations in all the arms, and to compare the active arms, we compared contact time and attention. So we can factor out those influences when we do the analysis. So in the active control, we chose non-directive counselling because at that time non-directive counselling was probably the most popular form of counselling for depression in the UK. So what did we do with the acupuncture? So the important thing, well, we chose a TCM style. We wanted practitioners to do individualized acupuncture, so they would take into account the presenting symptoms. And I'll come back to the presenting symptoms, because when patients consult with depression, it's not only depression that they often come with. 3 years experience and the members of the British Acupuncture Council, and they agreed to provide acupuncture as they normally would. So they're looking at routine acupuncture. And for the counselling intervention, it was humanistic, non-directive, already provided by many people in the UK, so it would be a very good control in terms of its being routinely available. And again, those counsellors were encouraged to practice as they normally would. So we had a few research questions. The key ones were, is acupuncture clinically effective and cost effective? The cost effective was particularly important because prior to this, the NICE guidance for back pain had recommended acupuncture on the basis of good cost-effectiveness evidence. And our assumption was that if we have good cost-effectiveness evidence, then NICE would then automatically consider recommending acupuncture. I have to say that didn't happen, and I'll come to that shortly. Is counselling clinically effective and cost-effective? And then this is where we adjusted for time and attention. How do acupuncture and counselling compare? Which is more effective than the other? We didn't expect a big difference between acupuncture and counselling, and that was one of the reasons when we randomized. Oops. Just trying to find the middle in the middle. Yeah, I got it. So this is our flow chart. We contacted 9,500 patients, recruited 755, and we randomized 2 to 2 to 1. So there's 302, 302, and 151. The reason, so this is acupuncture and counselling have got larger numbers because we're making a comparison of two interventions that are more likely to be more equal. And we followed up at 3, 6, 9, and 12 months. And we did all sorts of sub-studies looking at some text messages. I'll come to that. Interviews of various sorts, and also the questionnaire. Analysis, we did the intention to treat analysis. So the setting, this is in the north of England and in Yorkshire. We worked with 27 primary care practices who referred their patients, over 18, diagnosed by their GP, a baseline score of 20 or above on the Beck Depression Inventory. It's interesting. We ended up with, by having a score of 20 or above, we ended up with moderate to severe depression and moderate and severe depression. The reason we included severe depression was because we did a focus group with patients, and we put this question to them: should we have a cutoff? And the patients were very upset that the more severely depressed patients should be excluded, and they insisted, that severity shouldn't be a bar to being included in research. So this was a more challenging group of patients than we had anticipated. Sorry. And we excluded patients already receiving acupuncture or counselling, terminal illness, and so forth, and many other things were excluded. So this is our recruitment chart. We were very dynamic, especially in this zone here. We were under recruiting, and so we had to recruit a lot more GP practices and get more recruitment going. And then we were on a roll, and then we couldn't stop. And we ended up with 755 patients when our target was 640. When most studies under-recruit. And the reason is we bypassed the general practitioner and we worked with the practice managers. This was simply a logistic challenge to recruit. We just had to, so 9,500 patients were contacted to get our number. So what we were measuring for outcome The PHQ-9, that's the patient health questionnaire, number 9, that's a depression outcome. Also the Beck Depression Inventory, Euroqual, and we had many other outcomes. And then comparing, as I mentioned before, contact time and attention. We had a big sheaf of questions to ask. So what was the results? Oh, we haven't got there yet. So I'm getting ahead of myself. I get excited by the results. That's the motivating feature. So predominantly female, mean age 44, first age of depression at the age of 25. So this population has having repeated episodes of depression. 62% had severe depression. This created a huge challenge for us because we had felt we had a duty of care, so we had to monitor suicidality and so forth as a result. And so 69 were taking antidepressant medication. So this group are depressed, moderate or severe depression, and they're taking medication, which is not having a sufficient effect on their symptoms. So one of the things that was interesting was the take-up, that the fact that the patients who went to acupuncture, they received a mean of 10 sessions, and for counselling it was 9. The GPs we worked with couldn't believe that the patients would be so committed to their treatment, but they were very committed. And in terms of the acupuncturists, we recruited 23 acupuncturists who provided, on average, 12 treatments to 12 patients each. So in terms of generalizability, this is very much, what routine care is in that part of the north of England. And we documented all sorts of things. I can't go into the details of them in logbooks, the details of the treatment, what diagnosis they made, what theoretical framework they used, what sort of self-care they provided, and so forth. Okay, so we can get to the results now. So this is the chart. It shows the PHQ-9 score on the left. We were monitoring up to 12 months, and you can see the bottom line is the acupuncture, the middle line is the counselling, and the top line is the usual care. So what's interesting is that everybody gets better in the first 3 months, to some extent. So because people participate in these sorts of trials because they're having a bad patch. If you're feeling great and you're in remission, there's no point in coming into the trial. So this benefit happens as like naturally, spontaneously, and the challenge is for acupuncture and counselling to outperform the benefit that comes from usual care. So you can see we've got quite long-term effects. There was 12 sessions of acupuncture or counselling. That was all happening in pretty much all the first 3 months, and so the sustained benefit is a feature of this trial. So the clinical outcomes, we looked at one measure of the benefit is in terms of effect sizes. The counselling was 0.027 and the acupuncture 0.39. You'd say these are small to moderate benefits. They're not large benefits, but they were statistically significant benefits at 3 months. And the area under the curve, which is important for the cost effectiveness, was significant at 12 months. But after adjusting for time and attention, no differences between acupuncture and counselling. So basically there are 2 active treatments, and they're both similarly beneficial. So we did lots of sub-studies, which I can't go into all of them now because of the time, but I'm going to touch on the first 3 of these, which I'll just go into. But I've got, at the end of the talk, all the papers for all of these sub-studies are all listed at the end. So you can, when you access it on the web, you can get to look at the papers. All of the papers are open access, so it can be downloaded. So the text depression scores. So what we did, we automated a text going out every week, asking the question, how depressed are you? Please send us a single number back. 1 if you're not depressed at all, or 9 if you're extremely depressed, or any number in between. And what we didn't realize was that actually since every arm in this trial got this text, and it came, although from our point of view it was automated, for the person receiving the text, it felt like a really positive experience. So in a sense, it was actually an active intervention that all 3 arms got. And people said to us, especially in the usual care arm, how much they appreciated having a weekly text asking them how they were. So you can see we've got a similar improvement in these 3 arms in the trial, a bit more rugged, I don't know quite why. And what was interesting was we tracked where at what point did the difference become significant. And we found after 8 weeks, we had a significant difference. We've had a lot of talk about the different symptoms that come with depression. So what we did some in-depth work with a proportion of the patients. And we've got here, the symptoms of depression include all these, and each number here relates to a patient ID. And on the left, we've got pain. So you can see the pain circle is quite large. Fatigue is quite a large circle. Sleep, and so forth. So these are the symptoms we've been discussing earlier from previous talks. And that's why I think it's important we have a pragmatic trial, because the patients are treated individually and the symptoms can be taken into account when they get their treatment. So it's not one size fits all. So this is the 3rd sub-study, health economics. Interestingly, we found £4,500 was the cost per QALY gained. So that's under the threshold. We had the threshold of about 20,000. But the counselling was also cost effective, but nearly 8,000. The reason for the difference is almost primarily due to the cost per session. We were using standardized costings for the counselling, which was £65 per session, whereas the acupuncture was, most sessions were at £37.50. So that made the difference in terms of the cost per QALY. In other words, acupuncture and counselling came out very similarly in this study. So I had great faith in, as I said before, in health economics, and that would drive policy, and that was the theory. Here we come to the UK's National Institute for Clinical Excellence, for NICE. Every so many years they update the data. So when they updated the data just recently, they included this trial. And so what do they do with it? So it's interesting. So they said some nice things in the text, potentially promising results, a statistically significant effect on acupuncture on depressive symptoms compared to SSRIs, high rates of remission and response in those with less severe depression. That didn't really relate to our trial, but that was the sort of background statement. But then what they then did what's called a network meta-analysis. They pooled all the interventions for depression across the whole gamut of different possible treatments. And this is a terrible slide, I'm sorry, but you can see we've got yoga in here, and we've got exercise, treatment as usual, and then there's cognitive therapies of various sorts, behavioral and so forth. So each of these lines represents a trial. So where's the acupuncture? They decided not to include acupuncture, but they included the counselling arm of the trial in this network meta-analysis. So that was a bit depressing. You get depressed running a depression trial, I have to tell you. So acupuncture is not included because they're concerned that the populations in the acupuncture trials may differ from the general population. There were 3 trials from China out of 7. So there are 7 trials. Our trial, with the 755 patients, was by far the biggest. It was actually, I think, almost bigger than all the rest put together. But they basically said, right, we're not going to include the acupuncture in this network meta-analysis. So when they made the recommendations, they all came from the network meta-analysis. and acupuncture wasn't included. So the concern also that the acupuncture may not be generalizable. So that was, so you tick all the boxes. We ticked all the boxes in terms of a pragmatic trial, being high level, very thorough, very rigorous, doing everything right in terms of pragmatic trials. And, the evidence is still out there. When there's a change of, and I think that the politics of it, when that starts to shift, I think that evidence will be there to provide and inform guidance. But what happened with the Cochrane review? I've got another sorry tale to tell you. So I was part of this group that we did the Cochrane review in 2010, and I was argued with them. There's a team, and it's a Cochrane group. And so Cochrane has very strict rules about how you analyze the evidence. And they've, since between 2010 and 2018, they changed the criteria about how to assess trials, and especially to assess risk of bias. But anyway, just included with 64 randomized controlled trials, 7,000 patients. Out of the 64, 5 were undertaken in China, so it's the same problem to some extent. And also half the trials recruited from hospitals. So it's not a particularly relevant population for the West. But what they did is they did lots of, I'm saying they because the reason I'm saying they is I pulled out of this. This is their acupuncture versus no treatment. So it's showing that the diamond here shows an effect of 0.56, which is quite a big effect size. And the confidence intervals show that it's statistically significant, and it includes my trial, and it was along with Rosa's trials, 2 trials. Yeah. So this is that's a good result, and then we also did they also did the. I'm confused. This is the control versus the sham control. This is the diamond here. You see the diamond is just touching and crossing the line of no effect, which is this vertical line here, and the confidence intervals are shown here to cross 0, and yeah, I argued with them about that. We had standardized mean differences, which are free of units. Here they used a mean difference on the Hamilton scale, so you can't actually compare the two. But anyway, I guess this is quite a lot of interventions of acupuncture have non-significant effects of acupuncture versus sham. So this is not untypical. So this is what came out in the result: a moderate reduction of severity of depression compared to usual care, and a small reduction in severity when compared to control. But in both cases, the results, this is the bit I disagreed with. In both cases, the results were rated as providing low quality evidence. And the particular issue was the blinding. Because our trial wasn't blinded, it was automatically triggered a risk of bias that meant it could never be considered to have a good level of evidence. But if you think about the research question, we answered our research question, which didn't require, in fact, blinding would have been inappropriate. In other words, the Cochrane reviews are moving towards raising the importance of blinding in the way they analyze results in reviews. So I'm going to finish on a more positive note. Yeah. So this is Irving Kirsch, who works with Ted Kapchuk, and Claudia, does he work with you as well? No?
He has been here.
He's been here? Yeah, he's the placebo man. Yeah. Anyway, he did the study, and on the right-hand side, you can see acupuncture comes out, comparing with all the other commonly used treatments for depression. This is what we should have had in the NICE guidance, and we should have had a better profile in the Cochrane review. So, just to summarize, there's challenges to antidepressants. the research evidence is not that great. With the largest trial of acupuncture for depression, we've shown acupuncture and counselling both outperform usual care. Both treatments are cost-effective at 12 months. But despite all this good work, I'm disappointed about the limited impact we've had in terms of policy, in terms of the profile of our work, or the potential for acupuncture to deliver credible evidence. So lots of people have helped me with this research. It was 5 years of my life. I survived. And at the end here, these are the main papers that came out of the study. So if you wanted to access on the web after this conference, you'll be able to tap into these studies. Thank you very much.